I'm going to give a little bit of background about black women's health in the UK. My research has focused very much on African Caribbean women in the UK, but I think a lot of what I have to say relates to all black women, that is African women and other women in the UK who experience racism and discrimination. I'm going to say a little bit about why we need a black women's health study in the UK. Should do that towards the end. So my presentation is about the politics of black women's health, the intersection of race, class and gender in policy, practice and research. So why do we need to focus on African Caribbean women and health? Even though we have a large number of black and minority ethnic communities and research on the health of black and minority ethnic communities, in the UK, for some reason, African Caribbean women's health falls off the agenda. It could be that we have a large number of African Caribbean women actually working in the NHS because a lot of women, particularly who came in the post-Windrush era, came to work within the NHS. And so there's an assumption that because black women are working in the NHS, they have knowledge and control of their own health. Again, although in the US there is emphasis on the research on black women's health, there isn't that emphasis here in the UK. And as an academic, I wonder, well, why are we not researching black women's health? The research on black women in the UK tends to focus on education, motherhood, employment, identity, which are all really important areas. But of course, I would argue that health is integral actually to all of those. We do have a number of fairly disparate health research projects, and over the years that I've been working in health, I've been at the Open University for 20 years, but prior to that I was the head of health promotion in two different West Midlands services, so worked very much with communities. And so I've started to map where different researchers are doing research on black women's health. If I go back to something that Angela Davis said in 1983, which is how many years ago, it's so important and so relevant to the UK that we need to contextualise black women's health, that it's not just about medical and clinical issues, but it's about the social and economic and political factors that assail our health and well-being. Talking about African Caribbean women, there's a bit of a myth, both within the African Caribbean community and outside of the African Caribbean community, the myth of the strong black woman. The strong black woman who is working, is studying, who doesn't experience stress. If we look at the statistics, black women have the highest levels of full-time working. White women are much more likely to be working part-time. So when you think that a lot of black women are working full-time and at the same time they may be the key people with responsibility for their families, you can start to see the kinds of stresses that black women may be under. And as well as being involved in professional and managerial work, African Caribbean women are often employed in part-time, insecure work. And these are the very jobs that are at risk in economic downturns, such as the period we're in now, where austerity is having a real effect on black women. A lot of the services that are being decommissioned, cleaning, so we've got cleaning services within local authorities, within hospitals, are actually going to private companies. And it's in those very services that black women may be working. We have a vast literature actually on discrimination of black nurses within the NHS. There are still very few black women in senior management positions within the NHS. And the recent reorganisations of the NHS in the last decade, with the change from primary care trusts, many primary care trusts have used it as an opportunity to displace black senior managers. There's been research on this, and I know it from my own network of black women who suddenly find themselves as the first people to be made unemployed. We've also, within the NHS, had a period of performance-related pay, and there have been studies which show that black women are less likely to be offered performance-related pay when compared to white women and to their Asian colleagues. So we can see a huge amount of discrimination within our lovely NHS. As I said before, black women are less likely to be represented in senior management within the NHS, but they're actually more likely to be involved in disciplinaries, grievances, bullying and harassment cases, and capability reviews. That was from a 2008 study, but a recent study in 2006 actually reinforces this. So black women are more likely to be harassed and bullied at work. And we must think about the health implications of going into work on a day-to-day basis and being bullied and harassed. If we look at some of the other health concerns, black women are more likely are 5 times more likely to have high blood pressure and twice as likely to die of stroke than white women. The African Caribbean people, that's men and women, are between 3 and 6 times more likely to be diagnosed with schizophrenia. Just going back to talking about hypertension, even though black women are more likely to have high blood pressure, black men are more likely to receive treatment and to receive diagnosis. So there's a differential issue there in terms of gender. Research by Higginbottom also showed that black women who had strokes were likely to have strokes after a stressful period at work. And therefore, as I said before, we need to be able to link the experiences of black women at work and at home with their health issues. We also have a long tradition of black women working in what were state-run organisations like British Rail, which is no longer state-run, but also the NHS and social services. And here we have a situation where, because of the austerity cuts, all people, and black women in particular, may be put under more stress at work because of cuts in services and because they're expected to do more. And they're under more stress because they may be experiencing, as I said, bullying and harassment. And the context of having kind of high blood pressure, this may be further exacerbated by the fact that they may be working with racist colleagues and line managers. In relation to mental health, there's been a paucity of work on mental health and black women. And I think that is because the focus of work around schizophrenia has been on men, big, bad and black. So we have not had so much focus on women, but there is a very high level of anxiety and depression amongst African Caribbean women. Just the toll of everyday living and working in a racist society may take its toll on the psychological well-being of African Caribbean women, and there's research on this. The National Service Framework for Mental Health, sort of quite some time ago, 20 years ago, showed that black women were probably 60 times higher than white women to have rates of depression, but least likely to receive treatment. Now, that can be for a whole host of reasons. It can be the kind of cultural and traditional views that black women have, that we're strong. We don't need to actually seek services for mental health. We must be able to cope with it. But it may also be because services are not appropriate for black women. We haven't got mental health services that are set up to treat black women appropriately. We need more black women counsellors. We need more people who understand the context in which black women live, who understand about the toll of racism and discrimination on our day-to-day lives. Just going on very quickly to talk about breast cancer, we had very little data on breast cancer in black British women. And a study by Rebecca Bowen and colleagues in 2008 reported that black women presented on average 21 years younger than white women, and that their tumours were much, much more aggressive, and that black women were twice as likely to die of breast cancer. And when I read these statistics and there's kind of no response from the media, I'm thinking, whoa, why aren't our concerns taken seriously? There are lots of current concerns, and I'm just going to touch on these and mention them very quickly. In relation to organ donation, we have fewer people in black communities donating organs. In vitro fertilisation is another big issue. And one of the issues that has already been mentioned is the issue of maternal mortality. How can it be in a civilised society with an NHS that black women are 5 times more likely to die from complications in pregnancy and childbirth? And it can't be all down to FGM, I'm afraid. There are a whole host of reasons why black women are more likely to die. And we're not researching those reasons. We don't know what the reasons are. Why are we not researching them? Because to me, it's a horrific statistic, because that is the tip of the iceberg, that black women are 5 times more likely to die. But underneath the death, there is a whole block of morbidity that is sitting on top of. That black women's health is worse than white women's health. And why are we allowing this to continue? I said I'd mention very briefly, I don't know how I'm doing for time. Okay. In the US, and I know in the US there are far more African American women than we have black women in the UK. But they actually, because of the disparities in health between black women and white women, they set up a number of organisations. The Black Women's Health Imperative was founded in 1983 to look at this very issue. Why do we have racial differences in health outcomes? And the Black Women's Health Study at Boston University, that has been tracking African American women for the last 30 years. So they have an idea. They still have disparities and inequalities in health, but they have a better idea of what it is that is causing those disparities. And we need to have that here in the UK. Because black women are dying from preventable diseases. High blood pressure, strokes, coronary heart disease, maternal mortality. Black women are dying. Most of the research on women and women's health is on white women. You've all heard the phrase that black don't crack. Well, it does crack, and it is cracking. Black women are actually aging earlier. There's a whole kind of area of study called weathering, and because of the experiences of racism and discrimination that black women have, we are more likely to age earlier, physiologically to age earlier. There are so many conditions that we don't know very much about, sarcoidosis and lupus, and where we are not focusing sufficient funding on research. So at the Open University, we have set up a Black Women's Health and Wellbeing Research Network, which has a number of people who are involved in research across the UK. Dawn Edge, who's been doing research on black women and perinatal mortality, and now on schizophrenia at Manchester University. We also have Laura Serrant, who's at Manchester Metropolitan University, other colleagues at the Open University, where we're starting to bring people together to talk about what research findings there are, and we organise seminars and conferences. So just to conclude, the health of African Caribbean women is inextricably linked to our socioeconomic position, our work experience, our home life, and our experiences of everyday racism. And by everyday racism, I mean everyday racism. It's the kind of racism that sometimes when it happens, you're not even sure it's racism, because it might be a comment. It's not somebody coming and calling you I don't have to say the words, but it might be somebody who might be well-meaning, who says, "Can I touch your hair?" So it's those sorts of things that happen to us every day which are experiences of racism. And so we really need more research on the health of black women. Often the research that looks at race and ethnicity has focused on men. The work that looks at gender has focused on women and not on black women. So we really need to address that. And we need to make sure that the research that we do looks at the intersections of race, gender and class and the complexity of black women's lives. And just to finally conclude, Mullins and Schultz argue that health disparities based on race, racism, class and gender and sexism are matters of life and death. And they really are matters of life and death.